Hello. Today our case was presented in the Cardiomilitary 17th edition under title of Triple C, the Rapid Response Forces in CTO Combat. Uh, this case is actually a male patient, 67 years old, hypertensive, non diabetic, ischemic heart disease, had previous CABG 9 years ago. He complaining of typical anginal pain, Canadian Cardiovascular Society 3, ECG showing ST segment changes in the inferior and lateral leads, echocardiographic showing a mild impairment of ejection fractions, 53%, and a mild mitral regurg and segmental wall motion abnormalities in the mid and the apical posterior and the basal septal inferior walls, hypokinesia. MPI also demonstrating that there is ischemia at the inferior and the posterior walls of the LV. Before redoing a coronary angiography, this patient did a coronary multi-slice coronary angiography, and that coronary angiography demonstrating that there is a patent lemma to the LED, while the all venous grafts, including the venous graft to the distal RCA and the graft to the D1, was also occluded. So we go direct to the cath lab and doing a coronary angiography, and as we see here from this picture that there is a significant continuing lesion of a distal left main to the circ, and as we see that the circ is not dominant circ, but it actually gives retrograde collaterals to the distal big RCA, it seems. So we did a coronary angiography of the RCA, and as we see there is a distal complete occlusion before the crux. So we go directly to do a coronary intervention of the distal left main crossover with the LCX, a simple wire, Floby wire, and pre-dilatation with a regular balloon. Then a direct stenting with a pot, as we see here. So as we see here that the flow become more prominent, and fortunately this retrograde collaterals become more prominent, showing clearly the distal how the distal RCA is big and branched. So I don't know why I have the courage to proceed with the RCA, native RCA opening. I use two wires, one Floby wire and the other is a Pilot 150, and I managed, fortunately, to reach the distal part of the RCA with the two wires, and I start doing a pre-dilatation with the regular balloons. And as we see here, the RCA is opened, and I fix it with two stents. Very big RCA, distally very well demonstrated branches, long branches. Now, as we all know that the retrograde collaterals in this situation after opening the native coronary artery should be completely fading out. So I went to the left system and I take another angio, and as we all know, and as it is so clear that the retrograde collaterals completely fading out. One of my colleagues asked me in this demonstration that it suppose that the graft is opened, but I told him I did coronary angio and surfing for a patent graft, but as the coronary CT confirming that all venous grafts are occluded. And if this correct, so why is the circ giving a well-formed retrograde collaterals as we see in the previous angio. So this rapid fadeness of the retrograde collaterals was put in my mind the questions: does this rapid fadeness of the collaterals could lead us to know exactly what is the time of occlusion of the chronic total occlusion of the distal RCA or not? After revising the review of literature, that this was as previously, after opening the lift system, the retrograde collaterals become more prominent, and after the opening the native artery, as we see in the previous angio, that the retrograde collaterals completely fadeness out within about 30 minutes at the time of the procedure. So in this example, the collateral channels or the coronary collateral connections, or a triple C, act like army specialized dedicated forces. As there is occlusion, they become prominent, as this in this figure, and once the native vessels opened, they become sink down in the river. So they act like a specialized forces. وإن عدتم عدنا. So, as we all know that from this architecture, that the heart is full of interconnecting channels, even epicardial or microchannels, as looks like in this demonstration. And as we all know that this figure demonstrating that I resembling this triple force or triple C force like the 777 and the 999 in our Egyptian army, and it is from the side of joking, as we are in a military conference. So I suppose that the triple C forces of the coronary collateral connections looks like a triple dedicated forces, military forces like a 777 and the 999 forces, like as we all know the Delta Force of the US and how they kidnapping the president of Venezuela. So, to go in our science, the coronary collateral connections having, as we all know, an older classification, which is a Rintrop classification, and the practical Gerard-Werner score, coronary collateral connection score, CC0, CC1, 2, and 3, and how the CC3 looks like more than 1 millimeter diameter of direct connections, and it is a very well deformed, connection that help us to do a retrograde surfing and retrograde collateral CTO approach. I have some of the modification of the Gerard-Werner coronary collateral connections by my own speculation, ELSHAFEY speculation, and to cut it short, it depends on the inverted grayscale of the coronary angio, or the negative picture of the coronary angio. It looks like more demonstrative and more clear, and after doing this, I could upgrading one grade of the Gerard-Werner score by my own speculation. As we see here, if you using a regular angio, you couldn't demonstrate well the channel, but after inverting grayscale with some modification of the characters of the picture, you could demonstrate a well-formed and straight connecting channels. You could use it as a roadmap, and you go direct surfing these channels particularly, and I think it will lead to the distal target vessel. So the timeline of the collateral fadeness, it depends on several factors, including immediately post-procedure, The collateral function is significantly attenuated immediately after antegrade blood flow is restored. The second is the short term, it weeks to 3 months. A first significant decrease in collateral function is observed over the first few months. The long term, 5 months and beyond, the functional regression continues and stabilizes over the long term. There is another factors influencing regression: the vessel size, the small diameter coronary collateral CC0 collaterals undergoes the most rapid and complete functional regression, while the larger well-developed collaterals like CC2 are better preserved and remain more readily recruitable. So the second issue is the restoration of flow. The disappearance is largely flow dependent, and if the recanalized vessel remains open with high flow, collaterals are no longer called into action. Another issue is the recanalization technique. The method used to open the CTO, antegrade versus retrograde, doesn't significantly impact how quickly collaterals fade. Re-occlusion potential: if the CTO vessel re-occludes, collaterals have the potential to recover to their pre-interventional levels, so this process may take time. So to conclude, the coronary collateral circulation is a natural network of small blood vessels that form alternative pathways between coronary arteries, acting as a natural bypasses to supply blood to the myocardium if a main artery becomes blocked or severely narrowed. Well-developed coronary collateral connections reduce mortality and prevent large-scale necrosis. Coronary collateral connections don't normalize heart function. Ischemia persists during exercise. High-quality coronary collateral connections are the essential highway for the retrograde PCI approach. Successful PCI leads to coronary collateral connection regression and improved remote donor vessel flow. And thank you.